Hi, welcome back to Nursing with Bonomi.
I'm Nurse Nay, and today we're going to talk about the do's and don'ts of documenting. Okay, let's talk about the do's and don'ts of documenting. So, writing progress notes. So, there are some things that you should always document, and there are some things you should never document. So, these are my own personal opinions, but these are my recommendations just from my experience and what I've learned. So, something that you always want to document is if a medication was refused and that you notified the PCP. It's important that the PCP knows that a medication was refused. If you have a patient that continually refuses medications, the same medication, you can ask to have that medication discontinued. There's no sense in having an order for a medication that the patient just continues to refuse, because you have to document every single time the patient refuses, and you have to document that you tried to get them to take the medication, that you tried to talk them into it, that you tried to encourage them to take it, and you educated them a couple times at least. Okay, another thing that you always need to document, which may feel strange, is direct statements, even expletives. If a patient makes a statement, especially if they're really mean statements, make sure you document that, because those behaviors need to be known in the medical record. Also, if a patient verbalizes understanding, you can simply document patient verbalizes understanding of education provided. You can also document if they are refusing things. Document patient stated, I don't want to take that pill because da 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 da. So you can never go wrong documenting direct statements from the patient, unless they're accusing you of something. Don't document that in a direct. Don't document that. Something else you should always document: new orders. If a doctor prescribes a new order, you want to document that in the patient medical record. You want to document what the order is, and you also need to notify the patient if they're alert and oriented, and or the family, depending on the family dynamics. If the patient is alert and oriented, technically you don't need to notify the family. However, you may have a situation where the family is super involved in their care and they would like to know anytime a new order is given and the patient is okay with that. In that case, it's good to notify the family. You always need to notify family if the patient has dementia or they're confused, the family or the guardian. Another thing that you should always document is refusal of personal care. If a patient refuses a bath, or if they refuse to have pericare performed, that's really important to document, because not having those things done can impact the resident negatively. So it's super important to document that the patient refused it. And in that case, you can also put in the direct patient statement. And it's very important, like for showers, that the nurse double checks and makes sure that the patient is refusing and that they cannot be encouraged to have a shower, because sometimes they just might be concerned about this or that and they might need reassurance from the nurse, or there might just be a different way to approach them that might work to get them into the shower. Something else you should document: if a patient is on antibiotics, you want to document their effectiveness. So you can just do a very simple note. For instance, if a patient is on a medication for a UTI, you can just put patient continues on Bactrim for UTI, no adverse effects noted, patient denies discomfort upon urination, and no frequency present. Done. So you documented the efficacy of the antibiotic, and that's important. So, and that will depend on the facility policy, how often they want you to document it, if they have like a flow sheet that you're documenting it in, or if you are actually writing out a progress note for it. So always follow your facility policy for any of these things. Something else you should document is anytime you speak with a family member. Yes. I have had instances where family members insisted that I did not call them, that nobody had talked to them on the phone, and they were just straight lying because I had talked to them. After that happened a few times, I'm like, you know what? I am documenting that I talked to this lady because she's going to call back and say nobody talked to her. So I started doing that super quick, just family member updated to patient's current status, done. Or especially if you're returning a voicemail and they don't answer, you just put that in your progress note as well. Returned voicemail, no answer, message left to return call. It's important you document that, because then again, they may say nobody has contacted us, nobody has talked to us, and that's a problem. If they complain to state and they say nobody here has tried to include us in their care plan, nobody's talked to us, nobody's given us an update, if there's no record in the documentation that somebody actually did try to talk to them, you have no leg to stand on. It's like what they say goes. So you have to cover yourself and take credit for the work that you actually did. Another thing you always need to document is, of course, admission, discharge, and a death. If you have a death, you always want to document what funeral home the body was sent to. You want to make sure and document that the physician or nurse practitioner is aware, that the family was notified, that there was an order to release the body, which when I worked, you actually put that in as a separate order, but that's facility policy again. And also document where the valuables went, like if they were wearing their wedding ring, document that the daughter took the wedding ring home, or that it stayed on the body. It's important to note where those went, and you may have a paper to fill out that has those things on it as well. When you're documenting an admission, you want to document the date, the time, the diagnosis, why are they there, a general assessment that you did, and that you reviewed medications with the patient. That's a Medicare guideline that medications have to be reviewed with the patient, I believe, within 24 hours of admission. So just, you're going to give them a printout and just do that real quick and document that you reviewed it with the patient after you do review it with the patient. And a lot of times you're going to have a flow sheet. If you guys use Point Click Care, you have a flow sheet where you put your whole assessment in, but I'm talking about a separate progress note that you want to do with the date, the time, the diagnosis, and that you reviewed meds with the patient. And you can put in a brief note about the assessment, or just put in head-to-toe assessment performed. Also, it would be good to include like vital signs stable upon admission, no complaints of pain, patient oriented to room and call light provided, that kind of thing. And if you ever document that something is abnormal, say somebody has a blood pressure of 180 over like 100, you can't just put that in the chart and be like, oh, well, they got high blood pressure today. No, you have to let the physician know about that, and you have to document that you notified the physician. Even if they don't do anything about it, it's fine. Just document blood pressure 180 over 100, PCP notified, no new order, or PCP notified, new order to give 1 extra dose of, you know, metoprolol or whatever. Just document that. You can't, if you document something that's abnormal and you don't document that you did something about it, that looks like you kind of didn't do anything about it. Even if you did, you have to document that you did do what you did. Okay, so just as a recap, some things that you should always document: med refusal and that the PCP is aware, direct statements, even including expletives, new orders, refusal of personal care or showers, effectiveness of antibiotics, anytime you talk to a family member, if there's a death, an admission, discharge. When you do have a discharge, you also need to document the date, time that was discharged, who took them home, and that vital signs were stable upon discharge. And then the last thing you should always document is whenever something is abnormal. Those are super important. And don't forget my progress note ebook that is for sale, that has a list like this, as well as all the sample progress notes that I talked about. So you can have your own list like this. And it also has, check out the links in the description box to get your progress note ebook. We also have lots of free resources on there to help you guys out in your nursing practice. Let's talk about what you should never document. Don't document staff names. That's just wrong. You wouldn't want somebody to put your name in a patient's medical record. Like, just don't do that. I don't have any specific reason for that. I don't think that it's a Medicare rule that you can't document names. It's just kind of a courtesy to staff members that you don't put their names in a medical record that the patient could access later, and it just opens up room for litigation, like, oh, that is who it was. It's just, don't do that to your fellow staff members. I don't know, I just don't like that. That's my personal opinion, and like I said, follow your facility protocols and what your manager tells you to do. Don't document CNA refused to da-da-da-da-da. That is bad. Don't document that. That right there is money for the state surveyors. That right there, What you need to do if the CNA is refusing care is, that's going to be useless putting it in the medical record. What you need to do is notify your manager. You need to talk to that CNA about doing their job, and it may result in that person being written up. And that's what you need to do in that situation. It's not a medical situation to where it should go in the medical chart. It's a staffing situation. It's a disciplinary situation. So they're two separate things. So there's just no need to document that a staff member refused to treat a patient. There's no reason to do that. It's pointless. And it just causes more problems. It's better to say found on floor when a patient falls, unless you witnessed the fall, because you don't know unless you actually saw them. Did they fall? Did they lower themselves to the floor? How did they actually get on the floor? It's just better, just write found on floor. Pressure ulcer, that's another phrase that you don't want to use unless you're using it on a new admission, because if you document pressure ulcer, that's done. It's in the record. That's proof a patient acquired a pressure ulcer in-house, which means that they acquired a pressure ulcer while staying at the long-term care facility. You don't want to put that. Put it on a new admission. Put it if you have been given that responsibility, if you're the wound nurse and it has been diagnosed by the practitioner, then put it in the chart. Otherwise, just stick with reddened area or small open area, because it might not be a pressure ulcer. And once it is set as a pressure ulcer, you can't take that away. So that's important. Also, if you have a fall and you complete an incident report is an internal document only. So state surveyors don't have access to those unless the nurse documents incident report completed. Bingo! Now they can say, oh, the incident report was put in here as part of the medical record. I would like to see that. So what you put in the incident report is probably going to be a little bit different than what you document in the medical chart. You're going to put a lot more like details on the incident report. You can put there like certain things that you think contributed to the fall. It's more of like a working, thinking paper, trying to identify what the cause of the fall was. And that's not something that you usually would put in the medical chart. Okay, also, another thing to never document is at all times for an intervention. So, say a patient falls, and your intervention is for them to wear non-skid socks because they didn't have proper footwear on when they fell. Here's the problem with documenting at all times. If you put the intervention, patient to wear non-skid socks at all times, what happens if they take their socks off? If they take their socks off and they're off and the state surveyor walks in there and their care plan says that they're supposed to have non-skid socks on at all time, done. You're not following their plan of care because they're not wearing it. What's better to document is patient to wear non-skid socks as tolerated. Encourage patient to wear non-skid socks as tolerated. Putting that as tolerated in there takes into account the fact that the patient might take their own socks off. And you can't force a patient to wear socks all the time. They might take them off, and that's just the way it is. So that goes back to having a care plan that is patient-centered and takes into account the fact that the patient is a person and they're going to do stuff like that. Another thing you should never document is statement like, patient was nasty and rude. I'll do that. That is a subjective statement. You should only document objectively. Instead, what you can do is quote their direct statements. If they use a racial slur, if they curse, document that. And that's what you put instead of patient was nasty and rude. It tells a much better story, because if you read that, patient was nasty and rude, what does that even mean? Like, that might mean something, a patient might say something to one person that sounded nasty and rude, but to another person it didn't. So, just need to be objective, not subjective when documenting. So, those are your do's and don'ts of documenting. I hope that this was helpful for you. Share it with a friend, and thank you for watching. Have a fabulous day.